No. Okay, thanks everybody, and welcome to Spine Conference. And just so you know, David, the person who learns the most from Spine Conference is me.
It's you? Yeah.
Yeah,
Oh, that's good. That's
because
a good thing, though.
because I think a lot, and
In preparing it.
no, but in one's life, I'm not trying to philosophize, but I think in one's life, there's a few times when you actually step backwards and think about what you're doing, and it sounds silly, but I think it's true. So when you do a conference, you really step back and you think, what am I doing here? What did I do? And you learn a lot, from those instances in your life, And unless you do a conference, you don't really do that.
I would think so.
Yeah.
I don't know. Which of us can not step back and say, maybe we should have done things a little bit differently.
Right, exactly, exactly. Okay. So today's conference is postoperative sciatica following an L405 posterior instrument fusion. So this case is a 65-year-old woman who presented to the office with left sciatica. And Aaron, this is your laser pointer. Yeah, use the laser pointer to show everybody here. Is it working? Don't hit me in the eye. There you go. Good. So 65-year-old with left sciatica. She had the symptoms. She says, I've had these symptoms for 6 weeks. Pain runs down her left buttock, left lateral thigh to her left lateral malleolus. Our past medical history is rheumatoid arthritis. She had a right total knee replacement, hypertension, anemia, paroxysmal atrial fibrillation. Her medications, lansoprazole, metoprolol, Antera, sertraline, leflutamide, aspirin, Humira, digoxin, cardizem, Lyrica. So she's mildly, immunosuppressed as a result of these medicines, probably. She's married, very pleasant, nice woman. She's originally from Germany. Height's 5 feet 1 inches, 188 pounds. And is there anything else anybody wants to know about her history? So left sciatica. And Aaron, these are the X-rays. What do you show everybody what you see on the X-rays? So it's a great one. Good morning, Alan. Yeah, so it says, just to bring you up to speed, 65-year-old woman with left sciatica. 6 weeks of left sciatica. Okay. Yeah, so L405 is spondylolisthesis, decreased disc height. Show everybody what a normal disc is. And then the decreased disc height of L405. Good morning, Brian. And what else? Anything else? AP view? Front view? Pretty straight, right? I would say maybe the facets are a little bit sclerotic at L405. Show everybody L405, maybe. Okay, any questions about the X-ray so far? Okay, so the X-rays show L405 spondylolisthesis. So how about the MRI? On the MRI? What's the white color from? Yeah, so water signals normal L5. Interestingly, L5S1 is our only normal disc, right? Interesting. The rest are all dark. So that's kind of interesting. Why that disc is normal. I mean, I always wonder, like, some kind of familial predisposition for some people to get this disease, but most people lose the water to their discs. Usually starts about Ashley's age, right there. That's when it starts, and usually it's the young people that have horrible back pain. As we get older, the back pain is not as severe. I don't know why. Okay, anything else on the MRI? A little bit up there. Okay. So her. It could be, but it's small.
Yeah.
It's small, but I want to. I want to go quickly through these portions. So basically, L405 spondylolisthesis. She also had a large left L405 disc herniation. So she failed non-operative. What would you guys do is therapy for L4 sciatica, L4-5 spondylolisthesis?
For the spinal,
Yeah.
we would probably just treat her like we treat most patients with core stability.
Mm-hmm.
And if she had neural symptoms, treating it with like nerve glides.
Nerve glides?
If she was having neural symptoms.
She did nurse. What's a nerve glide? I don't know what that is.
Oh,
Nerve glide,
and
right?
maybe, yeah, we may not have done it. It depends on our presentation.
That's okay. What is it? I don't know what it is.
You're just stretching the nerve, basically. Sometimes it helps.
How do you stretch a nerve?
So if you're doing and this is from her back, so I'm not sure it would do anything, but if she had like more sciatic symptoms, we would stretch it, see if it increased her pain, and then have them do like a slump position, and then you put them, I mean, this may already cause it, and you could bring them over like this and internally rotate the leg as well as adduct, and you just bring it over until they kind of turn it on, and then you have them turn it on, turn it off, turn it on, turn it off. And sometimes that helps relieve neural symptoms for people.
Okay. All right. So she had a full decompression from L3 to L5 only on the left because the right side was not painful. So I just decompressed the left side, and then L4, L5 I did an instrument infusion because of the spondylolisthesis, because I had to fully decompress that level. I felt that it was necessary basically. During the operation, on the right side, I inserted a 6 millimeter screw, which is kind of the standard screw for this patient at that level. And I had very poor purchase. So I didn't like the fact that I had very poor purchase. Like the screw didn't feel that it was in something strong. So I thought maybe I was lateral or in the wrong place. So I pulled it out and I explored it with a probe I have, and I felt it, and it felt like it was in the perfect position. So I thought maybe she just has a very large pedicle. Let me put a slightly bigger screw. So I inserted a 7 millimeter screw, which felt perfect, and the X-ray looked perfect. So I kind of stopped there. Case was done, and then afterwards, the patient did great. She had absolutely no pain in her leg. She was walking around. She felt great. So is that the end of the story, you think? No, right? It can't be. But let's talk. What? So let's talk about pedicle screws. Like, why do we use pedicle screws? Brian, why do we use pedicle screws? Why? Why can't I just use it without screws? Why can't I just? Yeah, let's stop right there. So it's good. So think of a forearm fracture. If it can still heal, I mean, think of all those millions of kids you see in elementary school with casts on. All of those fractures heal, and adult fractures can heal too. But it increases the chances of it healing if the bones are next to each other. So it increases the chance of healing. So think of a spinal fusion as a fracture where you're trying to get two separate bones become one bone. Same thing as a fracture. So fixation increases the probability of healing. So when it comes to spinal fusion, the rate of spinal fusion goes from, the companies say 50%, they're probably lying, but it's probably like 60%, maybe 70, to more like 90, 95%. So it significantly increases your chances of healing. So, but you don't need screws of fixation to heal. So look at this tibia fracture, for example. It eventually goes on to heal. And when it does heal without fixation, there's motion. And what the body does, it creates a massive wad of callus. And then after a long time, the bone resorbs and modifies itself, and it looks normal again. It can look normal. Like a child's tibia will look completely normal in 2 years. An adult's tibia never looks totally normal, but it starts to look more normal. So fixation, that's what fixation does. Does anybody have questions? Why we use fixation, fusion, and fractures? Okay, so let's just talk a little bit about screws. It may be a little bit of an aside, but I think it's kind of important. So the screw has an outer diameter, which is big D, capital D, which includes the threads. It has an inner diameter, So when we make a screw, put in a screw, we put an awl, which is smaller than the inner diameter, and then we tap the inner diameter distance. So, and then we put in the screw, so it catches because the threads go a little bit more into the bone. So that's how you put in a screw. So you have the screw, the pitch is between, the pitch we describe as the distance between the two threads. So the larger the pitch, the faster the screw goes in. And then you have the neck of the screw, which is thick because it's a relative weak area, and then the head of the screw. So that kind of describes the parts of this pedicle screw. So pedicle screws are a big business. Brian, I'm not trying to. He's not even listening, so we're good. No, it's good. No, it's good. It's good. Good. I don't want him to get insulted, but like this is just a neurosurgeon's experience of two different companies, of two different surgeries. He put in 6 screws in both cases, which is like probably an L2 to L4 fusion, and the costs can be tremendously different. And there's a lot of money involved with these pedicle screws, as you can. Brian can tell you later.
What are they made of?
Titanium now. Titanium because they're MRI compatible. So we get MRIs after surgery often now. It used to be not, but now often. So when I say that I thought the screw was lateral, this is what I'm talking about. The screw is lateral. See that? It's lateral to its optimal position. The other side's optimal, totally encased in the bone. But this is lateral. This screw still works, but intuitively you can see it's not as strong as the other one. It holds the bone a lot better if it's completely inside. And being lateral can cause other problems too, but one is it just doesn't work well. If it doesn't work well, there's a lower chance that the bone will fuse itself. Sometimes the screws can be medial. So you can see this screw on the right is medial to its normal position, and that's where the nerve root lives. The nerve root lives immediately adjacent to the pedicle, so they can hit the nerve root and cause pain. So this is a problem. If you have a screw thread up against a nerve root, you have to remove it. So medial is a problem too. So what's in, out, in? Some screws you can't, some spines you cannot put a screw in. Like even though the implant representatives always say you can put a screw into anything, not true. Some things you just can't do it. But this is an option if the pedicle is too small, is you can miss the pedicle but stay lateral and then get into the vertebral body. Yeah, and this is most common, like in the thoracic spine, where it's hard to get a strong screw. And you do get fixation in this manner. But if in the thoracic spine especially, there can be a problem. You can see if you're lateral in the thoracic spine, you can compress the aorta, which is a serious problem. And patients have died from this, from hitting the aorta and not recognizing it. Yeah, well, it usually presents as just postoperatively is a tachycardia, believe it or not. When I was on call one night at Johns Hopkins, patient, I was like 3 in the morning, and you covered like 50 patients in the hospital. They called me. He's like, the spine patient's tachycardic. And I thought about it. I was like, well, let's get a CAT scan of his chest because he had a huge spine. Sure enough, he had a huge hematoma in the chest. So I called the spine fellow and I said, I think you guys hit the aorta during the surgery. And he was angry. He said, it's impossible, really angry. I was like, well, maybe you can explain it somehow else, but there's a big wad of blood where the screws were. So it's something that you always have to think about where the relevant anatomy is. So that's why, Aaron, I always say on the left, I usually end my screws at the 75-yard line of the vertebral body. Show them where the 75-yard line of the vertebral body is, right about there. Just a ballpark measure, the screw should never go past that point. And if you do that, then very low probability you'll hit the aorta if you're lateral. So we're talking about screws. Just the anatomy is the central spinal canal, and then the nerve exits the frame, and show them the nerve root. It's already exited the frame in there. And there's a big wad of muscle called the psoas, shown in the front and the anteriorly. Now, Aaron, this is extra point. If you get this, you get a bonus, which will be like maybe a candy bar. That's the only bonus I can afford. Show them the nerve root above, not the nerve root at this level, but the nerve root above. From the where is it? Where does it lay? It's right there. This is the nerve root above. See it? From the higher level. So you can spear that nerve root. Let me show you another anatomical study. So here's I don't know if this makes sense to you guys, but this is a coronal section of the spine. And show them the pedicles. That's a pedicle. Patient's head is on the right, buttocks is on the left. So that's a pedicle. First of all, notice that the pedicle is not round. God did not shape pedicles for screws, but we have to use round screws. And show medially, you see how the nerve root is right up against the pedicle medially? See that? Right there. So that's why, remember I said if the screw's medial, you'll hit the nerve root for sure. But then lateral to the pedicle, there's a nerve root there too. See it? Right here. See that? So if you're lateral, you'll hit that nerve root. And most people don't think like that, but that nerve root's there, and I've seen that before too. I've seen that years, like a patient had sciatica years post-operatively and came back and I said, look, the screw's lateral, it's hitting the nerve root. So here's another MRI. See the arrow is pointing right to the nerve root, which is lateral to the pedicle, and that's the nerve root above. The other important thing, the frame and the hole where the nerve exits is where the dorsal root ganglion is, right there. And that's the dorsal root ganglion. There's a lot of neuroceptive peptides there, so it's extremely sensitive. So the dorsal root ganglion of the nerve root is where the two nerve rootlets come together, the dorsal ventral nerve root, they come together, and it has their cell bodies in there. It's extremely painful if something's compressed there in the dorsal root ganglion. So if you have anything there, it's extremely painful. Okay, so these are, after saying all this stuff, it's going to make sense when we go over this case. Another problem you can have with the pedicle screw is it can get loose. And this is called the halo loosening sign. So you can imagine if that screw moves inside the bone, it can erode the bone and like a windshield wiper and make a hole. So if we see that, that's called the halo loosening sign. And if the bone doesn't fuse, if the two bones don't come together in time, the motion that you get from the level, because there's still motion there, never fused, it can create a halo loosening sign and the screws can get loose. So if you get a CAT scan of a halo loosening sign, that's what it looks like. The bone's never healed, and now the spine just keeps moving because the spine moves between two bones, and then the area around the screw erodes and the fixation gets even worse. So for those that are motivated and you want to read about pedicle screws and inserting them, this is a great lecture you can find online by the chairman of neurosurgery at Case Western Reserve. It's a great resource. I read it this morning. He did a really good job. And this is just it's just another way to put in pedicle screws, cortical pedicle screw, which goes lateral. This is not the typical way to. This is not the way I do pedicle screws, but apparently it's easier. And she was fine. Maybe we're gonna. Okay, so I'm glad David had to say something. So let's get back to the patient. So why does the patient's leg hurt? The patient initially had left leg pain, and it was gone. And 2 weeks later, I saw her 2-week post-op, no pain whatsoever, nothing. But infusions, we followed them for 6 weeks. When she came back 5 weeks, she said, now the other leg hurts, right sciatica, the other leg, right buttock, right sciatica. So I gave her a steroid pack, nothing. I gave her medicines, nothing. She finally came back 7 weeks. I was like, well, we got to figure this out. So, and I'm going to answer your question, Dave, 1 second. So what's the differential diagnosis of postoperative sciatica? Let's say early, like the next day, it could be the screws hitting the nerve. There's a good chance, and you got to get it. Basically, anybody with sciatica, I get a CAT scan, make sure the screws are in good position. You could have a traction neuropraxia. If you pull on the nerve during the surgery to decompress it, that can give you nerve pain. You can have stenosis from malalignment. Maybe you shifted the bones, now something's hitting the nerve. Inadequate decompression is another thing. Maybe you didn't do a good enough job. Maybe you thought you took the pressure off the nerves, but it's not enough, and there's still pressure there. The other thing is maybe it's a distracted. Maybe you did one surgery that removed the distracting injury, and now another thing comes to light. In other words, you fixed the most painful problem, and now that's gone. Something else hurts too. So that's another thing it could be. Now, so she's not early. Those are early reasons. Late reasons are it could be an infection. Remember, this patient's on Humira, rheumatoid arthritis. She's immunosuppressed a little bit. It could be new stenosis, like maybe she has a pinched nerve at another level. It could be the screws are loose and it's hitting the nerve. Maybe it's kind of nerve problem. It's got nothing to do with the surgery. It could be a hip problem. It could be a pelvic problem or instability. Maybe the bones are shifting. Early, yes. Early hematoma. Like within a week or two, it could be hematoma. This is 7 weeks out now, but hematoma could be early. I've seen that happen too. So her X-rays, post-op X-rays, just 7 weeks out, look perfectly normal. Screws are in good position. You can see the fusion mass posterior laterally. Aaron, show them the fusion mass. That's to see the bones are fusing fine. So I did flexion extension views. This is flexion extension. On the left is flexion, right is extension. No abnormal motion. Screws don't look loose. So then I did an MRI. Aaron, show them the seroma. She still had a big seroma of just fluid. Yeah, show them where the screws are. There's that black lines where the screws are. Now, if those things were stainless steel, Alan, you have this huge black mark from the stainless steel. But titanium gives just very little artifact. But everything looked okay. Here are the axial cuts, L3, L4. Aaron, show them the right side of the patient. So that's the right side. Nerve looks fine at L3, L4, so there's no problems above. Here's where here's the level of L4 pedicle screws. So you see the black line that it causes. So you can't really tell. You can't make any comment on whether the screws are hitting the nerve root with an MRI. You need a CAT scan because it throws off that big shadow. You see that? But there's no hematoma, like David said. There's no infection. There's no abscess. Now L4, L5, the lateral recess is a little bit stenotic. Aaron, show them the lateral recess. See how that's a little bit compressed? So I did not decompress the right side because she had no right side symptoms, but maybe it's just a little bit of residual stenosis. And it's not severe, but it's present. Here's at L5. Again, you can't comment on the screws because it's a big artifact, but nothing looks bad. L5S1 is totally normal. So this is just, I want to show you guys, this is where I took my bone graft from. Aaron, show them the bone graft site. To the ilium. Right there. See that? That's where I took my bone graft and I fill it back up with allograft bone, with dead person bone. And eventually that becomes normal. I just wanted to show you what that looks like. So here's the CAT scan. So in the CAT scan, you can see the screws a lot better. But that right screw, remember I told you it's a 7mm screw? It's really close, isn't it, to the spinal canal? But if you work the lighting of the image, you can see it's in the pedicle, but just barely, but it's in. So it's probably, it's got a little bit of an angle, but it's still in. That's okay. It's the biggest possible screw you could put in probably. And the other interesting thing about the screws is you see how the pitch is different in the screws? Like distally, the pitch is larger than proximally. Why is that, Brian? Why is the pitch different? Okay, so this is in the most superior aspect of the L4 pedicle screw. On the right, I did find something. What's that thing? What's that, Aaron? It's a fracture of the pedicle. There shouldn't be a fracture there. It doesn't look like it's compressing anything. And this is the inferior aspect of the pedicle. It's not fractured. L5 looked okay. Again, this is where I show them where I took my bone graft. You can see those little cubes. Those are allograft dead person bones where I took all this. You don't have to, but why not? And if you fill it, no, what happens is it's better for the patient because it's a totally normal bone afterwards. And then, yeah, a lot of people say they have bone graft site pain. When I do this to patients and I'm careful about reattaching the muscles, they have no bone graft pain at all. So I think taking good care of where you harvest the bone decreases postoperative pain. But it does cost like like $400 or something, but I think it significantly decreases post-op pain. So just one more view of the fracture here at L4 on the sagittal cut. And on the coronal cuts, it looked totally normal. But note the asymmetric shape of the pedicle. Like the pedicle is not a circle, and the screw is a circle. So you have to think of that when you put them in. But everything else looked normal. So just so you know, when you fracture something, you can remember we said callus. You can lay down callus, and this is a case of a pars fracture, where you can see the fracture. You see how the bone's bigger. It's laying down callus and it's trying to heal. So this is a child's humerus, and you see all the white fluffy stuff around the fracture. That's a massive amount of callus that kids grow to get it to heal. So a fracture that's not fixated lays down a lot of callus to get it to heal. And just so you know, you can see this callus, but that's not necessarily the truth. If there's no calcium in the callus, if it's an early callus, it's not calcified, you can't see it on x-ray. You only see things on x-ray that are calcified. So when you have a fracture, you could have a massive callus that you don't see on the x-ray. So just so you understand how callus works is you break a bone and then it bleeds, hematoma, and then fibrocartilaginous cells grow around the fracture, and blood vessels grow, and then it becomes immature bone first, and then it becomes mature bone, and that's a fracture callus, and so that's how we respond. So my thoughts, so what are people's thoughts? Any thoughts about this fracture of the pedicle on the right? I know that's what I said to her. I said, look, it's fixed. This will probably all go away. Just give it a little bit of time. I thought maybe it was the pain from the fracture. Once the fracture heals, you're going to get better. Those were my thoughts. But she did not get better. And then I thought, let me inject some steroids into the nerve, give you some more time, maybe the fracture will heal, you'll get better. It didn't get better. So what are other people's thoughts? What do I do with her? What do I do? Ignore it? The Center of Pain Management? Psychiatric consult for me or the patient? For me, yeah, I do need it. So she can't live with this pain. So I took her back, and this is what I did. I explored the nerve roots, and I fully explored all the nerve roots. And I don't have this to tell you, but I'll tell you what I found is she had a massive amount of callus from the fracture really compressing her nerve root that you could not see on any of the images. And it was not calcified. That's why you couldn't see it. But it was there. It was hard. And I fully explored both nerve roots, and I took both screws on the right out because they weren't really doing anything because there was a fracture there. And the surgery took about an hour and a half. And they didn't have any problems. And what were Aaron, tell the results. Yeah, pain gone magically. So on the one hand, and this is her post-op x-ray. So now she just has screws on the left, but that should be sufficient. You know, she should go on to fuse and be 100% fine. So on the one hand, I didn't want to do an extra operation on this patient. If she didn't need it, the whole thing's going to go away. But obviously this thing was not going away. It was like 6 months, 7 months. So she went home like the next day, pain totally gone. So the only other, so that's it for this case. The only other issues are, what if the callus grows back? I mean, impossible. But she's so widely decompressed, I think her nerves have plenty of room, even if some callus forms.
Well, that's because I'm sure you didn't want to go back.
You never want to go back in because it looks like you as a doctor feel like you have failure. Patient feels like things failed. The hospital gets in trouble, but you have to do what's right. And and it's hard. It's hard, especially for a surgeon to go back on your own patient. That's why patients a lot of times it takes another surgeon to do it. But you have to do what's right for people. And the other thing is I always say to myself, one is you always have to do what's right, and second is it's an imperfect world. Things aren't always perfect.
There must be some way of imaging callus. You're saying, you do CT, you see the fracture, you see bone, but you don't see callus.
I don't know if you can. I mean, like ultrasound maybe, but
we CT the abdomen, we see soft tissue.
Yeah, but it's so small you don't see it. It's so, I mean, it's like this couple millimeters. I mean, the CAT scan and MRI scans, they sometimes they're not sensitive enough to pick these things up. I mean, basically, they just a lot of times. I tell this to Aaron all the time. The CAT scan, the MRI scan, they just tell us where the problem is. They don't tell us exactly what the problem is, but they tell us where the problem is. Like a bone scan, just tells you where the problem is.
Yeah.
It doesn't tell you exactly what the problem is. So it could be infection, cancer, or whatever. All right. So that's any other questions with this case? So it's basically a case of when what I think what happened is when I inserted the big screw, there was just a tiny crack, but it wasn't big enough break where I noticed the screw was loose or there was any problems. I didn't see anything, and then eventually this fracture just got a little bit worse post-op and started developing callus. That's what happened. So the implant companies always say put the biggest screw possible, right, Brian? No, no. What does the implant company say? What size screw? What size screw do we put in? Also, you don't need to put in a big screw. Like you just need the bones to be still enough to get the bones to heal. That's all the point of the screws are. Or get loose or whatever. Yeah. Yeah, and there's a lot of surgeons feel like I'm a big surgeon. I have a big ego. I'm putting in a big screw because it's scary to use big screws, but I'm a big person. I'm going to put in big. Seriously, I mean, that's out there in the world, and it's it's not always the best thing to put in the biggest screw. You just need an implant that will hold the bone still to get the bones to fuse together. That's the most important thing. Too long. It's true. Yeah, but the problem is we look at our X-rays afterwards, and we want things to be perfect. I've probably done almost every bad thing you could do. I think you just haven't known me my whole life. But everybody makes mistakes. Right. You can. I mean, like you said though, things can get worse, and you have to. It's hard. It's a judgment call.
I've seen
Yeah.
a guy go on the patient with a crack on the fracture of the pedicle on one side and the pars on the other.
Yeah. Right here. So this is a pars fracture. I mean, 1 in 20 people have pars fractures, and they don't heal. They commonly don't heal in adults, and they lay down callus and they can compress the nerve roots. So it's a common. It's probably more common than 1 in 20. That's just our American research. But there was a study in China where they placed children in CAT scanners. And you can only do this in China. In the United States, people won't stand for it because of the radiation involved. But they put a bunch of children in CAT scanners, and they wanted to see the incidence of pars fractures, and they found a 10% incidence. In other words, 10% of all children, 1 in 10 children, have a pars fracture. They're very common. We could never do that study in the United States because it's just a lot of radiation in children. So and it's interesting. So people walk around with all these things, and there are inherent weaknesses in the bones that people have, and they lay down callus and they can compress nerve roots. It's most common.
You were saying about the big cost of the screws. What did 1 mil screw cost? Several $100.
Maybe more. And what's the range, Brian? Can you tell me a range? Wow, that's more than I would have said.
Right.
You can get them for cheaper though. You get a volume discount. Brian can't tell you that.
They do.
Brian works for Depew Synthes, which is a Johnson and Johnson. They're big. Are you the biggest in the country?
For spines?
Yeah.
When,
You are Medtronic, right?
yeah, Medtronic was
Just about even. How about in the world? We're the biggest market, I'm sure, right? Yeah. For spine. It's a lot of money. All right. So, so any other questions about today's discussion? All right. Thanks, guys. See you next
Thank you
month.
very much.
You're welcome. You're welcome.